Thank you. I'm delighted to be here. I want to bring a bioinformatic audience into how I feel and how I think as a public health physician and data scientist. Civic AI for global health will become clearer throughout this talk. Why do we need to bridge between the civic and the global? The world is facing many challenges, and I am disappointed that much of our attention on AI is distracted into short-term gain. We face rising pressures from the resource diversion in health systems into conflict and climate change that's not going to get any better. We face antimicrobial resistance, preparing for the next pandemic, winter pressures from seasonal epidemics, more people living longer with multiple long-term conditions, diminishing social care impacting healthcare, a long tail of obesity. 40% of Liverpool's population are estimated to have fatty liver, the biggest rising risk factor in cardiovascular disease. Prevention and self-care get insufficient attention. And we have very siloed approach. Discovery science and our experimentation on diseases and specialties, not on whole patient journeys. And AI is busy automating that siloed way of working. Why do we need to change? This feedback loop follows decades of common sense. Observe, intervene, create a flywheel effect to pull through data closer to action and titrate that action to optimize. In the 1980s and 90s, it was called closing the audit loop, very provider quality improvement centric. Then in informatics in the 2000s, we started to refer to learning health systems, really taking a semantic web approach to pulling through dynamic evidence closer to action and improving the streams of data linked together, but more driven by algorithms in that continuous improvement. Now we face an opportunity of creating through learning loops as AIs tap into the rhythms of our lives around the person, the provider, and the population. As a population health physician, this really worries me. By 2035, we estimate that more than 2/3 of the UK's population will be living with more than one long-term condition. Most drugs and treatments haven't been designed to treat combinations of conditions. There is a need to close that loop, understand, and titrate our interventions accordingly. So discovery science and implementation need to come a lot closer together. Here's the simple things that we do through automation with our data flows. We're lucky in this country to have a lot of structured data, but an estimated 4.1% of NHS prescriptions contain an obvious error. A simple rule base could scour these, send a notification to the GP, and our patients ask for can we receive a message at the same time that we've been identified. The costs of not picking up medication harms early are much higher than the costs of driving for greater medication safety. Yet, we have very bad engineering in clinical systems. Clinicians face a blizzard of alerts and alert fatigue. But the big unknown is that 30 to 50% of medicines are not taken as prescribed. And we have very little knowledge of what happens after the prescription. So Liverpool's taking a learning systems approach that starts with the individual. Every scenario of safer medication is designed with members of the public, patients working with prescribers, bringing a number of personas, getting good design into pulling through the data and experimentation from big challenges like the harms created by combinations of medicines that haven't been trialed to be used in those combinations. Antimicrobial stewardship, transitions to save money, like switching to cheaper anticoagulants, the necessary population and provider approach, but our public seek an AI ally that is with them there for the journey, tells what to expect from medication. Not just notifications, please take your medicines, but a listening ally that will listen to the symptoms that you experience and the things you're afraid to tell the doctor, like the side effects that mean you don't really want to take that particular medicine, but you feel uncomfortable saying that in a clinic. If rhythms of people's lives and we know those change points, it is the ideal time to take a biological sample. And that takes me to my provocation about community biology. Our public want data to be used progressively. Last week in Liverpool, we launched a charter written by our communities on data and AI. A charter that starts with benefits. A charter that asks for balanced innovation of risks and benefits. Public very much pressing for action in areas like medicine safety that they want data to flow. We might be nervous about flowing some data, but that public demand is very strong. For more than 20 years, when a case has been made clear, and I've worked with members of the public, many years in Manchester and now in Liverpool, it's almost always a case of having your marching orders to use the data progressively and keep the public and patients in the loop. Very different to the headlines on the right, where the uses are not clear and things can blow up into confidentiality, security, solved problems with good governance, but poorly communicated. It gets pushed back. This is the approach that Liverpool has taken since 2019, when we started a civic data cooperative to democratize data uses, to really get that pull through in a population where I face a third of children still born in poverty. This population needs better uses of data, and they deserve better than nervousness about waiting for permission nationally. So we took matters into our own hands. Then the COVID-19 pandemic came along. The wheel clamps were off. Every civic system around the world had to respond, had to protect its population from COVID-19 and the consequences of lockdowns, the broader civic challenges of delivering healthcare whilst protecting the world from a pandemic and keeping civic functions going. We have taken this civic data cooperative approach throughout the route out of COVID, producing a mental health research for innovation centre and a civic health innovation lab. This is in response, this is a promise to our community. In COVID-19, same paging was the most important early result. So in 90 days, there was no shared care record in Liverpool. We linked data from primary care, secondary care, 30-minute feed on test results from national COVID testing systems. Put that together in 90 days, and the dashboards that were put together created a conversation between agencies which went along the lines of what are we going to do tomorrow together based on what we see today. And we get closer then to the flywheel effect of that learning system. It's more about people and the permission to communicate, to act together, to have joint accountability and to offer mutual aid. Yes, you see the spikes here of different variants in COVID-19, lateral flow test, PCR tests. This is actually the world's most characterized population for COVID testing. More than 18 million tests and a lot of research was done in Cheshire and Merseyside, that 2.7 million population around where you're sitting now. This is how it felt. So as a data scientist and public health physician, I'm faced with two headlines in local newspapers. One, hospitals might be overrun, particularly intensive care, as older people on a background of poverty and ill health were more susceptible to very severe COVID and more likely to die. On the other hand, young families in a population where half the economy depends on visitors, so the economy shuts down when people don't come in lockdowns. That means toxic stress for children growing up, which can have effects for the rest of their lives. And that balancing act I felt acutely. So it wasn't difficult for me to go into conversations with government in October 2020 of running the world's first lateral flow testing en masse across the city for everyone who lives or works in the city of Liverpool. With or without symptoms of COVID-19, testing was available. 2,000 soldiers mobilized. We actually had joint intelligence systems between the military for footfall in testing centers. We moved in real time the location of testing centers. That same paging was very real. That learning system was on a daily basis. The result was a decrease in cases by around a fifth and a decrease in hospitalization with severe COVID by a quarter. National agencies who didn't have context didn't get this analysis right. It's only months later when we had the All England data and could create in silico a little Liverpool comprised of little areas that had similar COVID restrictions, background, demographics, hospitalization rates, similar to Liverpool. A synthetic control analysis. The most conservative estimate was a 43% reduction in hospitalization with COVID, with a big push with the military in the first few weeks, and overall a 25% reduction in hospitalization, when Liverpool was testing and other places weren't. The importance of context in great analysis. We also reached into Civic sources. So this is the use of the Consumer Data Research Centre. When there was a proposal from government that people could only get lateral flow tests through an app, we said, well, what about digital poverty? And we had to prove it very quickly. So here we linked, because we had linked records for everyone, we had postcodes of residents, the small areas in which they lived linked the internet user classification. Digital poverty was a stronger predictor than multiple deprivation, the material poverty of getting COVID. So people with digital poverty were more likely to get COVID and less likely to get tested. We said to government, do not prescribe testing with lateral flow through an app, make it universal access. And we won that argument. That was the policy that was made. Coming out of COVID, mental health was a huge problem. We saw a tripling in anxiety in girls and young women, and referrals of very severe anxiety. So there was a big push on using a similar civic data approach to tackle the rising mental health and its interdigitation with broad aspects of society, household stress, and here benefits, wraparound support, social prescribing. Citizens' advice on prescription. This comes from the trust, where I'm on the board of a local trust, mental health and community services. So money's going in via the NHS, social prescribing with charity and voluntary sector here. The result is a decrease in antidepressant prescription and a decrease in acute presentation, hospital presentations with a very severe end of mental health. Again, a synthetic control analysis done very economic gain for our system. So if you can get that kind of fidelity in data, we can start engaging our communities in data about the rhythms of their lives. They want to give these data. This means that we face the possibility of discriminating these two endophenotypes, one with a rapid cycling there, A, and one with slow cycling, B. The clinics only sees infrequently, so the rhythmicity is invisible to the clinic, but this is essential for biodiscovery. We also get then closer to the destination the patient wants. Many patients with a mental health condition might say, I don't have a mental health condition, I have a sleep disorder. But what I really care about is my sleep. And there are elements of anxiety, depression, transdiagnostic categories, not blunt diagnoses, and destinations people care about. If we have temporally reflective, realistic data for discovery, i.e. more frequent observation and more experiences coming from people's lives, we need to get into lives in a way that is fair. We currently discriminate against those of low literacy and low health literacy by assuming that an app is the only way you're going to get experiential data. We're about to face a tipping point of voice-based AI. You can't get a bank account in India without speaking to some AI. So grasp that, tap into the rhythms of life, and there is a lot of potential transdiagnostic discovery. If I think about what the NHS knows about me, now I'm currently in my 3rd month of fexofenadine because I have extreme hay fever. And my goal is to maximize mental acuity that I need for my job, minimize alcohol, increase exercise, attention to sleep, and meal times, etc. There's a lot of self-experimentation happening, and I also get my fexofenadine over the counter, and I'm gluten intolerant, and I get my own B12 injections because it's more convenient. So my biology is basically invisible to the NHS, but I'm extremely motivated to offer those 3 months and within individual control that I am for multi-omic experimentation. What's happening with my biology? Many people are, and that's what our public involvement groups tell us. Prediction and interaction. Here, can we engineer the means of community biology into the normal way of healthcare? There are many different prediction models that are getting better. Few are currently used in healthcare compared with those that come out of research. But interoperate between different bits of health systems. It also becomes easier to tackle the market failure of a blizzard of apps, one app per device, per drug, per clinic. That means the patients with the greatest need, multiple conditions and multiple medicines, are burdened to an intolerable level by apps that don't talk to each other, AIs that cut across each other. We need to move from that app store mentality to a skill store of the digital you. And that means the skills of the digital you need to interoperate with lots of different predictive models that give you what-if scenario planning, sight of the road ahead. My physician's going to discuss with me different treatment options. What am I going to say about my preferences for the different potential effects of that medicine? It's a partnership of trust, prediction, interaction in a more joined up world. That is a civic approach where the learning is revealed to the individual who generates the most valuable data, the patient. The patient and their digital twin can come together in communities where there is collective endeavor. A quarter of this city's population came forward for COVID testing when there was a lot of negative publicity in the media. More than 3/4 of this population trust local government, less than a quarter trust national government. Community drive in civic places is very strong. So the digital kin of individuals should be recognized and not just thinking of therapeutic targets and discovery science, talking to individuals that are isolated from a community. I think if we create a grid of network communities and draw upon that socio-technical power, we can crowdsource a new kind of community biology, a discovery economy grounded in need. Thank you.
Thanks for giving this very inspirational talk about how to make use of the data better to improve the quality of healthcare. I was wondering that whether you have any comments on the type of data that, let's say, genomics information that could easily be identifiable to individual patients, how that type of data could be more liberally used or reused for this purpose?
Thank you. It's a very wise question. In Liverpool, we have a large collection of bioresources, and we've been thinking of a strategy to base the discovery potential, maximizing the discovery potential around phenotypes and not freezers. So if we're crowdsourcing higher definition phenotypes from highly participative populations, the strategies we have, which hasn't been announced yet, is called Live Me. My journey through care, instead of throwing away routine blood samples, if I'm signed up for biodiscovery, the great potential that lies in me contributing more phenotypic information, let's say when I've been discharged from hospital, is to have a repeat sample. So within individual contrasts, we increase statistical power by focusing on the tipping points. We enable studies, for example, of resilience, those who don't tip right down after a hospital admission, but are on an unusual steady state. I think the great potential there is for buying people in to that discovery journey, for socializing the unanswered questions and the importance of repeated sampling. I think particularly with multiomics, we can get a lot more out of people's engagement in that way, not just thinking of a list of different samples connected some way down the line to a care record, but much more involved, much more of a learning system approach.
Thank you very much, Iain. I think in the interest of keeping to the parallel tracks, we'll move on to the next one. But thank you very much, Iain.
Thank you.